I want to welcome everyone to the second joint session between the Texas Rural Health Association and the Big Country Area Health Education Center. Our first speaker today is going to be John Hernderson. Probably most everyone knows John. He's been around for quite a while. He's been the executive director for Torch since April 2018, and prior to that, he was the CEO of Childress Regional Medical Center. So without further ado, I'm going to turn it over to John Hernderson. John?
Thanks, Mike, and good morning, everybody. I'm trying to share my screen because I have a presentation I want to work through. I guess I should start by saying I'm sorry we can't be together in Abilene. I sure would like to see everyone. And it seems like the first 6 months of 2020 have been as consequential as any in my lifetime, but probably the next 100 days will be every bit as important as the last 100. I've been given 45 minutes to present. I'm not sure that I have 45 minutes of content, but I want to do 2 or 3 things. The first is work through a few slides that are basically rural healthcare, rural Texas healthcare 101, and talk about some of the, not just geography, but struggles and closures that'll be familiar to many of you on the call. But then obviously talk about COVID, not as much about the caseload and trends, because I really don't have access to any database or dashboard that any of you can't track and trend yourselves and be more specific to your region or county. But there are some things within the COVID story that I want to share, some encouraging things and some lessons learned, things of that nature. And then if we have time at the end before we turn it over to John Hawkins at THA, who can probably give a more complete political, regulatory, legislative update than I can, I'll either tell more stories or take some questions or finish early. And I bet that wouldn't hurt anybody's feelings. So I'm going to dive right in if that's okay. Feel free to jump in with questions or shoot something through the chat and we'll get them covered, okay? This is a map of rural Texas. As you know, rural in Texas most commonly is defined as county population of 60,000 or less. And by that criteria, there are 157 rural Texas hospitals currently. There used to be more. 146 of them are members of Torch. So as you know, I'm the president and CEO of the association, and more than 90% of the rural hospitals in Texas are members. 86 of those 157 are trauma designated, most level 4. And thanks to Mike and the folks at Preferred and the story out of Van Horn, the state recently released guidance on how to become level 4 trauma designated via telemedicine, which is kind of cool. Also 86 are designated as critical access. So a little bit more than half are trauma designated, a little bit more than half are critical access. The others are small PPS hospitals in Texas. We like to layer on top of that map a map of hospitals that still provide OB services, which is a trend that's diminishing in rural Texas, and those flesh-colored or beige counties are those without access to women's services or deliveries, and we call them OB deserts. There's a list there of the 64 that still do deliver babies, but some recent suspensions. Most recently, the hospital in Stephenville, which is actually a THR hospital, and then within the last couple of weeks, the hospital in Marble Falls, which is managed by Baylor Scott and White, announced that they would no longer be delivering babies, and they expect those mamas to go to either Fredericksburg or into West Austin, Lakeway area. That's a disturbing trend. National data shows that 44% of all rural hospitals have negative operating margins. Specific to Texas, we show that to be closer to 46%. And as you know, if you can't break even, you can't survive. Medicare margins specifically are -9%, and that's all provider types. Rural hospitals would probably be even less with the proliferation of Medicare Advantage plans and things of that nature. So that's resulted in rural hospital closures. We count 27 rural hospital closures in 22 communities. That's double any other state. Tennessee's second. They have more in terms of percentage, but because Texas is big and has more rural hospitals than any other state, we've also had more closures. As you can see, they're concentrated in mostly East and Southeast Texas, but that's started to change recently. As recently as last year, the hospital in Hamlin and the hospital in Chillicothe closed. In January, the hospital in Bowie closed again. So they had closed, reopened, and closed again in January of this year, just before the pandemic. Can you imagine living in Bowie and not having access to hospital or clinic? Actually, that's something I dialed in last week, and Dr. Phillips referenced that Bowie story, and I want to build on that just a little bit because we've seen the economic impact play out. Joyce Crumpler, who's the EDC director in Bowie, shared some of this data with us, and she says, you know, it's not just that they lost more than 100 jobs, it's that their sales tax revenue went down more than a third in the following year and another third the year after that. Their school enrollment dipped, which, as you know, is the way schools in Texas are financed. There are homes that were for sale when the hospital closed that are still on the market today, and businesses that chose not to locate to a community that can't provide access to health care. So you see that domino effect, and we talk about the three-legged stool, that you got to have health care, you got to have I'm flipping around. Three-legged stool, you got to have access to healthcare, you got to have good schools, and I say you have to have good churches. Some people say the third stool should be water, and I say that's fine. You design it however you want. But the closure crisis is real, and we remind people that rural hospitals in Texas were vulnerable before the pandemic. The pandemic kind of served to accelerate that. So shifting gears to COVID, we're kind of in unprecedented times. The trends in Texas are problematic. I read this morning that Austin, where I live, has a 20% positivity rate. It's gone from 5 to 20 in a month, and that's scary. Many of you probably listen in on these statewide calls with state leadership, where Houston literally is at capacity. San Antonio is not far behind. Specific to rural, you know, the first COVID death in Texas was in Matagorda County. One of the first flare-ups was in El Campo, and I'll show you some pictures of that. And still, the highest overall case rate in Texas was up in Moore County at the hospital in Dumas. They're the only rural county or community hospital I'm aware of currently that isn't seeing a little bit of an uptick in cases. And Jeff Turner, my friend Jeff, laughs and says that's because everybody's already had it up here. Along with COVID comes a whole new dialect or language. I used to joke with people and say, I don't speak 1115 waiver. Now I've got to learn all these terms around social distancing and N95, PPE, things of that nature. My family refers to coronavirus as Miss Rona. You can see that up in the top right. But there are all these words and cultural touchstones that just weren't familiar to any of us as recently as March of this year that we've learned. This is an interesting picture. The outbreak in China, to me, wasn't as scary as the reports I started seeing in March out of Italy with regard to bed capacity challenges and vent challenges specifically. Picture on the left is actually from 1966. It's an Easter service where there were more than 500,000 people in attendance. Picture on the right, I think, is from March 27th, outside of St. Peter's Square, where the Pope is actually praying by himself because of the situation on the ground in Italy. That really got our attention, and we started trying to understand what we could do to help our hospitals prepare. This is actually a picture of MOPAC in Austin, and it's one of the perks of stay-at-home orders and quarantine for me. I really miss the people in Childress, Texas, but I also miss my 3-minute commute. I had to go to a meeting in near the Capitol in April. I live 20 miles from downtown, and it usually takes me more than an hour because of traffic. Well, I went 90 miles an hour all the way down there just because I could. And I think I got to my meeting about 45 minutes early, but it was remarkable, the difference that a month made in just traffic patterns during the stay-at-home order. But there were problems related to that specific to rural healthcare. You know, most rural counties at that time did not have many, if any, COVID cases, and rural hospital CEOs would call and tell me that as much as 50 to 75% of their revenue comes from clinic visits or elective procedures and surgeries. And what we remind everyone we talk to down here is that elective in rural doesn't mean unnecessary. You know, there are things that can be scheduled and even deferred, but it's not without health consequences to the community you're trying to serve. So even though that's probably the right thing to do at the time for most Texas communities, it was really hard on rural hospitals in particular. Actually, it's hard on all hospitals. These are pictures from El Campo at the end of March. They were one of the first flare-ups. I think it was related to a HEB produce employee, but they were the first rural hospital that I'm aware of that set up testing outside of their facilities, and you can see the pictures of the tent there. As I said, the first death was in Bay City, Matagorda County, and then the big flare-up was up in the Panhandle, just north of Amarillo. I think that was late March and early April. Here's a quote from Linda Razor, who's one of my favorite people and retired in May. She said the virus hit Dimmitt and our, actually I can't see the end of my quote because of the way my screen's set up, but they got, their revenue was shot. And this was what we heard over and over again from rural hospital CEOs in late March, early April. Some version of we're on the ropes, not sure that we can make another pay cycle. We're either forcing some time off or doing some layoffs and some furloughs. And we counted, I think, more than 600 staffing reductions at a time when we were actually trying to build hospital capacity. And the pandemic reminds you of the importance of hospital capacity. And I had actually already talked about how more than nearly half of rural hospitals were operating at a loss. Economic hardship was also evident in unemployment numbers and all of the economic indicators that we watch. That's what makes, to me, the governor's job near impossible. And I don't envy those decisions at all as he tries to balance health outcomes with economic hardships. And there are consequences to staying hunkered down, no doubt. The good news on the economic hardship front is that during the month of April, there was congressional action and federal stimulus that flowed to our rural hospital members. I think that the first round of distributions from the Provider Relief Fund or CARES Act or second pass stimulus happened on Good Friday, which was April the 10th. There's about $30 billion that was distributed based on Medicare payments. There's a formula for that. And that ended up being about $300,000 per rural hospital. That was followed a couple of weeks later with a second pass, but that was based on net revenue, and it superseded the first pass. So we had a lot of hospitals that didn't get anything in that second $20 billion tranche. But they did start receiving Medicare accelerated payments, which are structured as a loan, not a grant, with payback after a year. They were blocked initially. Most rural hospitals are structured as public entities or hospital districts that were blocked initially from the SBA PPP program, but in late April, early May, and Congressman Arrington, who was on, I saw present on this call last week, was as important as anybody in that work to open the door to public hospitals in the PPP. And so many benefited from that. And we were talking about millions of dollars to rural Texas hospitals. And then the big one was on May the 6th, just after Cinco de Mayo. There was a targeted rural hospital and clinic distribution from the CARES Act of $10 billion based on a formula, depending on how many clinics you had. But most of our rural hospital members got between $3 and $4 million in that distribution, which was huge for them. So from May, when CEOs were calling saying we aren't going to make it, and I was worried about 10 or 12 more rural hospital closures, to the middle and end of May, where the calls shifted to rural hospital CFOs that you could tell weren't used to having cash in the bank, were calling to make sure that they knew reporting requirements, knew what strings were attached, terms and conditions, what was allowed, and things like that. I failed to mention that maybe the very first stimulus that our hospitals received was actually through the State Office of Rural Health and the SHIP grant, about $78,000 per hospital, really fast with very few strings attached. So that's a long-winded version of the other side of economic hardship, is that federal stimulus has been a big deal for our rural hospital members. And most rural hospital CEOs currently are telling me that they're going to be okay through the summer, regardless of what happens. No doubt there will be challenges that we had before, but thankfully we've avoided additional rural hospital closures because of some relief. Shifting gears just a little bit to lessons learned, and maybe it's a little too early, but we've started trying to gather some of these stories and lessons, and I don't want to spend a lot of time on them, but I do want to put a few things in front of you. You know, the importance of telling the truth. I heard someone present actually just this morning that for us to respond effectively in times of crisis like this, you need trust, not just in the government, but in science, in the media. And unfortunately, at the moment, I'm not sure that there's enough of that. You got to find what matters, and you got to find meaning. That very last bullet point on this slide is something we like to talk about, and what we actually led with on our most recent edition of our magazine called Rural Matters, is neighbors helping neighbors. And we've seen examples of that all over the state. That's actually what I like about rural generally, is most people don't ask for help unless they truly need it. But most of your friends and colleagues, if they know that you need something, would do anything they could to help you out. And I'm just not sure it's the same in urban environment. Good people, they're good people everywhere, but I just don't think they're as good about sharing and responding to need as country folks are. A few more lessons, and this is really, to me, about the importance of primary care and telemedicine. I really think that things are going to have to change when it comes to our healthcare delivery systems, and we're going to have to find ways to play offense instead of defense, because that's the way actually to control overall healthcare costs and improve the outcomes for the population. So you'll end up with better experience and better outcomes and happy patients, and hopefully we can get to payment mechanics that are fair and expand access for everyone. And there's always things that you can learn. Here are a few stories. I said that neighbors helping neighbors, and we saw the best in people. That mention of Danielle Turner in Dumas. This is both good and bad. There was a time during the crisis where they just couldn't get PPE and they were overrun. And Danielle, who's Jeff's wife, she figured out a way to sew washable surgical gowns from shower curtains. And not only did she do that for the hospital employees at Moore County, she put her design out online and offered her cell phone number to anybody that wanted to do that. You know, it's unfortunate that that was the circumstance. I really think that healthcare frontline workers have been the heroes in all this, even when we weren't able to get them what they needed to be safe and effective, but everybody did everything they could to respond. We were on an insurance call, statewide insurance call, when Jeff got on and was late to the call and said, "I'm sorry, but we're just covered up. We're having trouble transferring patients, and we're using every vent we have." And another hospital CEO in Gatesville, Texas, sent him a couple of vents the next day. Same thing happened down in El Campo when Nathan's crew was maxed out. The hospital in Columbus actually drove a couple of vents over and said, use these as long as you need them, and we'll let you know if and when we need them back. Examples of a hospital in Northeast Texas that said, I've got more N95 masks than I need at the moment. Let me know where I can send them. And then a month later, he needed gowns, and I put something out on the Torch listserv, and within an hour, we had sent him about 1,500 gowns. So those kind of stories are encouraging. The one that at the top from the LA Times, and Tom actually in his presentation last week tried to tell this story, but I'm going to give you my version. There was a article in the Texas Tribune that quoted a few of our hospital CEOs, I think Eastland and maybe Sweetwater, having trouble getting PPE. And I think before 6 o'clock one morning, Tom was texting me saying, I saw that article and I know a guy that's trying to get masks to a warehouse in East Austin from Mexico. Are you interested? And I said, let me do some checking. Well, everybody needed it and everybody wanted it, and the price seemed better than anything we could find. So I told him I would take all 60,000 of them and run and get them. Well, when I went to his warehouse, the quality on these things was nowhere near N95. So I threw a fit and told him to screw off and left, and drove around the corner to jump on a Zoom call like this for a staff meeting. But I started sending pictures to the people who had requested the masks, and they basically replied and said, something's better than nothing. Go back in there and renegotiate the price. And in one case from Hereford, they were going to fly down and get the mask and try to distribute them through the panhandle. The other thing that happened while I was around the corner on the Zoom call is I told Tom that I didn't like the quality and wasn't going to pay the price. And he said, just so you know, that guy, I think, is from Philadelphia and has mob ties. So be careful how you talk to him. And I thought, uh-oh, I wish I'd known that when I threw my little fit. And now I've got to go back in there and deal with him again. So I politely went back into the warehouse, found my guy, told him I might have been mistaken and that maybe his masks were worth a little something. And we renegotiated the price, and I started loading up my wife's car to make the distributions. And he asked me if I would go back into the back of his warehouse and because they had some tequila, and he wanted to do a tequila shot in the back of the warehouse. And I started thinking, where are they going to find my body? but I did live to tell about it. The other interesting mask story that I just wanted to share with y'all is Camila Alves, and I did not know who that was until I received a call from a member of the governor's strike force who we had been working with to try to get some vents to share across rural Texas. He called me, I think, on a Sunday afternoon and said, hey, I just got a call from Camila. do you know who that is? And I said, no, I'm sorry, I don't. And he said, well, you'll know her husband. His name's Matthew McConaughey. And I said, yeah, I've heard of him. She said, well, Camilla has some donated masks that she said to me she wants to get to the people who need it most. And I thought of rural hospitals and Torch. Could you help her with that? And I said, sure. Well, she not only got those masks to us, but she's been absolutely wonderful to work with and check in and offer more help and get more things to us. We were actually having a board meeting on a Thursday afternoon when she started texting me saying, hey, I have 100,000 not N95 but procedure masks that were donated by Ford Lincoln, which I think is funny given that they probably get their Fords and Lincolns for free. She said, I've got someone willing to make deliveries if any of the masks are going to go within 100 miles of Austin. Well, I was in a board meeting and distracted and not really picking up on what she was saying because she didn't mention him by name. And I said, no, you know, the closest hospital that needs them is in Hondo, which is down on the other side of San Antonio. It's probably 200 miles. And those masks are so light that it's actually more effective to just mail them. And she said, are you sure? Because I've got somebody ready to go. And I said, no, just get them to me and we'll mail them out. And I kind of poo-pooed her off like that and didn't take it seriously. Well, I got home that evening and my wife showed me a post that Matthew McConaughey had posted about being loaded with masks and ready to make deliveries to rural Texas hospitals. And so I really blew it on that one and got a lot of offers from female CEOs, particularly willing to drive, you know, to Lampasas to meet Matthew McConaughey and get masks. So I'm sorry I let y'all down on that one. One thing that I wanted to mention before we start trying to wrap up and shut down are the things that are likely going to change. We saw telemedicine as an emerging innovation prior to the pandemic in a way that could provide access to health care for underserved rural communities. This was actually my slide that we used after the 86th legislative session in 2019, showing some of the good things that came out of the session. But as I heard someone say, we've probably made 5 years worth of advancement in telemedicine in a couple of months during the pandemic. And it's just clear to me that we aren't going to go back. I don't think patients, if they can keep from it, are going to sit in a waiting room and, you know, have people coughing on them if it's not procedural stuff and if they can avoid it. So telemedicine is definitely here to stay, but the provisions that have allowed for the expansion of telemedicine and appropriate payment of telemedicine, a lot of them are still tied to the federal emergency declaration and the state orders through Medicaid. So one of our big legislative priorities heading into the next session, number one, is still going to be Medicaid payments at cost for rural hospitals. We got the bill to do that last session, but we need to keep filling that bucket because it wasn't adequately funded. But the other is telemedicine, specifically distant site telemedicine, which is allowed at the moment for rural health clinics, also for FQHCs, but that needs to be made permanent. And we need to demonstrate how that can be used effectively and lead to better outcomes in care and be money well spent. But if you haven't already figured out a way to deploy technology and you have stimulus money, we see that as a pretty good way to use it. And if you need help from us or people to talk to, of course, don't hesitate to do that. This is the last slide before I show you how to find me if you need to contact me, but we try to just remind people that rural is a place of significance. We love the optimism that we see in rural communities and rural leaders like you. We're connected. We know that community matters. And as I said, it's neighbors helping neighbors. And we're proud to be able to partner with you in that important work. This is my contact information. I think most of you know how to find me, but if you need anything at all, you can let me know. I've got 13 or 14 minutes left before we hand it over to John Hawkins at THA, and I don't know if he's connected yet, but I'll pause there and be happy to answer any questions that anybody might have or talk about anything that I might have missed. Hey, I see in the chat my friend Sue Lynn. I appreciate that, Sue Lynn, and miss you.
So John, what do you see as the biggest challenge? Can you kind of wrap it up? Tell us what's our biggest thing to be concerned about as far as the survival of our smallest rural hospitals?
Well, I think a challenge is going to be collaboration. You know, in Texas, most rural community hospitals are structured as hospital district with taxing authority, and they provide clinic care and hospital care and EMS care. But in most cases, that's independent, and it puts you at a real disadvantage when it comes to, you know, not just survival, but negotiating contracts, having any kind of leverage or purchasing power. And so I think one of the keys to survival is going to be our ability to work at least regionally, if not statewide. And the alternative to that would be some sort of system affiliation, but we see mixed results in rural community hospitals that do that. And so I'm not as big a fan of that. The other challenge I see, Mike, with regard to just advocacy at the federal level is the only reason we haven't had big problems is because of federal stimulus, and they are debating what will probably be the last substantive federal legislation before the election as we speak, and it looks like they're kind of stuck. So, you know, we're okay at the moment, but the trends in Texas for most communities are headed the wrong direction. We've got some challenging days in front of us. The governor, you know, reasserted his executive order for the 4 largest counties to not do elective surgery, and then expanded that yesterday to 4 additional counties in South Texas. If that were to continue and we find ourselves in the similar situation that we were in late March, early April, without, you know, PPP and without Medicare accelerated payments and without any kind of appetite in Washington to help, you start seeing not just rural hospitals, but, you know, restaurants and small businesses and, you know, commercial real estate start falling down, and the economic consequence of that would be devastating. Actually, specific to the 2021 state legislative session, which begins in January 2021, the estimates I've seen, not just because of the pandemic and the rise in unemployment, but things like the oil and gas drop out in West Texas. It was supposed to be the session about redistricting, but that's going to take a back seat to the budget, and we're starting to see estimates of a statewide budget shortfall that could be as much as $40 billion. And that's as brutal a session as you could ever imagine. So there are still definitely challenges in front of us. It'll take all of us working together to overcome them.
We've got one question from Carmen Onks. It says, are there any specific bills or legislative items that will impact rural health care that folks should keep an eye on?
Yeah, I don't know if she meant specifically at the state level or federal level. There are no state bills yet, but we're going to be looking to build upon SB 170 from last session, which was the bill that required the state to pay rural hospitals Medicaid costs, but it wasn't fully funded. So we'll try to build upon that. And of course, we'll be looking at some sort of distant site telemedicine bill, but it's too early to know specifically what those bills would be or who will sponsor them, but we can let you know when they do. At the federal level, there is a interesting proposal. We call it step down designation. It's actually Congressman Arrington was one of the authors, and I don't know the bill number off the top of my head. I want to say 5808, HR 5808, but that might not be right. I'll correct it if I'm wrong. But he calls it a rural emergency medical center, but it's basically those hospitals that have really low inpatient census and are vulnerable can go to a designation that would allow cost-based reimbursement without inpatient services. So you do emergency room and observation status only and still get your cost. But that requires federal legislation and a new designation for hospitals. And that has been around for a while. It just hasn't moved. We're trying to get it snuck into one of these stimulus bills rather than moving on its own. And then the other thing that is not specific to a bill number is that MFAR, which was Medicaid Fiscal Accountability Rule, has been kind of dormant, and CMS Administrator Verma had indicated to state Medicaid directors that they didn't intend to move forward with that rule because of the pandemic. Actually popped up yesterday on a CMS calendar to be finalized by September. So the MFAR fight seems to be re-emerging and will be a federal legislative priority. Hey, John Hawkins, I might have been right on my number, 5808 by Arrington. I'm trying to check this chat. Thank you, John.
I guess one last question from John Sims is saying, is Senate Bill 170 similar to emergency Medicaid to fund hospitalizations?
No. SB 170 was just Senator Perry's bill last session that requires the state to pay rural hospitals their Medicaid cost. When he says emergency Medicaid, I don't know specifically what he's talking about. But John, if you want to send me a note separately, I put my contact information on the presentation. I'll chase it down for you, okay?